All right, let's go ahead and get started. Well, hello, everyone. Welcome to today's Present Approaches to Testing webinar on genetic testing for pancreatitis. I'm Dr. Linda Hasadsri, the director of the Molecular Technologies Laboratory and a consultant within the Division of Laboratory Genetics and Genomics at Mayo Clinic in Rochester, Minnesota. I'll also be briefly co-presenting today alongside our main star, which is the wonderful Dr. Motaz Ashkar. Dr. Ashkar is a gastroenterologist and medical pancreatologist, also at Mayo Clinic Rochester, who not only diagnoses and directly takes care of the very patients who have genetic testing for pancreatitis each and every single day, but he's truly your go-to expert when it comes to this particular disease state. So this is definitely a treat. So just a couple of reminders for everyone before we begin. There will be a question and answer session at the end of the program. So you can submit your questions online via the Q&A icon on Zoom. That's at the bottom right of your screen. Please only use the chat function for any technical issues. Lastly, today's program is being recorded and will be posted to our website in a few weeks. And with that, I will turn things over to Dr. Ashkar.
Well, hello everyone, and thank you, Dr. Hasadsri, for this great honor to be presenting among this webinar with regard to a topic that's near and dear to me. So I am a gastroenterologist and a medical pancreatologist at Mayo Clinic in Rochester, and primarily within our pancreas clinic, we interact with benign as well as malignant pancreatic-related disorders, including those who could have been induced by an underlying genetic cause or etiology. Let's see if this would advance. Perfect. I have no particular disclosures that are relevant to this talk. Within the coming half hour or so, we'll try to go over a few objectives. Primarily, we're trying to sort of navigate through potential causes and workup for both acute and chronic pancreatitis, then bridging and linking between the entities of acute versus recurrent acute versus chronic pancreatitis, and then focusing at the bottom half of the presentation on different genetic mutations, pathways of how they can cause pancreatitis, and lastly, understand that basically when to order these tests, and at the same time, how are they correlated with other pancreatic diseases, primarily pancreatic cancer. So a little bit of background about acute pancreatitis. This is a very common medical problem in the United States. It is the third most common cause of a hospital admission in the United States from a GI related etiology, and that does cost the healthcare system quite a bit. North to 2 billion a year has been invested in caring for individuals with acute pancreatitis. But despite the fact that there is a great recognition of the disease, the incidence of it is increasing. But the good part is that we're able to sort of capture severe disease and deal with this mortality and be able to reduce that mortality. But we're still dealing with quite a bit of morbidity. So in this graph in particular, you would see a little bit of incline in the incidence, and likely the fact that there are other factors that come in play that are basically being increased in our social life, whether it's smoking or alcohol use or even obesity. But yet we're doing quite a bit of great work in reducing mortality from this disease. Now, when it comes to acute pancreatitis, we have particular criteria that we look at to be able to tell us whether this is truly a case of acute pancreatitis or not. And this is coming from the Revised Atlantic Classification or criteria. What we typically need is 2 out of those 3 to fulfill the diagnosis. So think of it at a high level. When it comes to a potential case of acute pancreatitis, we look at the clinical presentation, biochemical values, in addition to radiological evidence of inflammation. So typically patients would come in with acute pain that's basically in the epigastric region, radiate to the back, and they could have elevated serum pancreatic enzymes level, typically lipase or amylase, that's at least 3 times above the normal value. And lastly, on imaging, whether this is through a CT scan or MRI, you would see evidence of pancreatic inflammation. 2 out of those 3 would be sufficient to diagnose a case with acute pancreatitis. Be aware of the following fact that amylase and lipase levels could be elevated in other conditions, and they have sort of a half-life of when they're up and then eventually they're normalized. So amylase, as an example, it can go up and peak within about half a day, and it declines within about 3 to 5 days afterwards. But the reason we select a cutoff of 3 times above the normal limit is the fact that these enzymes could be elevated in other conditions, such as basically salivary gland related conditions, or ovarian cysts, or ovaritis, or if there's basically small bowel obstruction or ischemic bowel. Similarly, lipase can go up, but yet sooner, within about one day it could peak, and then it could stay elevated for almost a week. The same causes for amylase elevation can cause also lipase elevation, but this is a much more specific pancreas enzyme. So when we are dealing with a case of acute pancreatitis, there are numerous reasons or etiologies that can cause this insult to the pancreas. Granted, if you look at this pie chart, you'll see the 3 main causes are kind of centered around gallbladder or biliary causes in north to 40% of patients. And then you have alcohol and or smoking independently can cause acute pancreatitis in about 30 to 35%. And then you have this chunk of 20% to 25% of patients that could have disease of an unknown etiology. And then the rest would be high triglyceride, hypercalcemia, autoimmune diseases, medications, in addition to probably an underlying genetic etiology by means of about 1 to 2%. So it's an extensive list, and then we have to basically be a little bit of we have to do a little bit of detective work to sort of navigate through these possibilities and find out who would likely fill in which bucket. Our purpose in clinical medicine is trying to limit the number of patients that are labeled with idiopathic disease, because likely there is a cause, but we're not there yet to identify that cause. Now, moving to chronic pancreatitis, historically, this means basically progressive pancreatic inflammatory and fibroinflammatory state that could result in these irreversible changes within the pancreas, both the duct as well as the parenchyma. And in certain cases, it can cause pain, or it could cause loss of the pancreas function, whether it's at an exocrine level or an endocrine level. And this diagnosis, up until the mid 80s, was based off basically a combination of clinical presentation, but also histological evidence. And since 1984, ERCP was used through a classification system called Cambridge classification as a surrogate to tell us that this is likely a case of chronic pancreatitis. But the problem with this type of method is it does not help us in identifying a cause, knowing an early disease state, and also this could result in delay in treatment, or even providing a patient with sort of a preventative type of treatment plan. And therefore, there was a new mechanistic definition in 2016 that included additional information to what we know about chronic pancreatitis. So the morphological changes, they're not as just sort of high level description, but rather they're specific to atrophy, fibrosis, strictures, evidence of calcifications. But also, this definition added causes, including genetic or basically environmental risk factors, such as, again, alcohol or heavy smoking exposure. That being said, chronic pancreatitis is still common in the United States, but it's not as common as acute pancreatitis. It would cause up to 50,000 hospitalization annually in the United States, and there is data that this probably is overinflated because of how we code cases based off their hospitalization using, let's say, an ICD code, so that sometimes could be overstated. But yet, if you look at the disease in and of itself, it is not an uncommon condition. And we tend to see it more in men compared to females in the US. Severe disease is more common in black versus white, and that is likely related to exposures to certain toxins or toxins-mediated disorders, as in, again, alcohol and or smoking exposure. It is subdivided into a large duct disease versus a small duct disease. Here's an analysis that basically highlights the incidence of chronic pancreatitis. I typically cite the one at the bottom, which is a chart review based study that came out of Mayo in 2006, and that gave us an incidence of about 41.8 per 100,000 per year. And as I said, it's more commonly seen in men. Now, there are multiple reasons why we could be at risk for chronic pancreatitis. Traditionally, the thought of only alcohol or idiopathic disease or genetic induced or obstructive or hypertriglyceridemia was the limitation of the potential causes of chronic pancreatitis. But later on, this got expanded to include a mnemonic of TIG-RO. Each letter would represent a category. So T stands for toxins. So that would be alcohol. It could be heavy smoking exposure, hypercalcemia, high triglycerides. Certain medications can cause the disease. And then the I stands for idiopathic, and that could be an early onset disease versus a late onset disease or tropical. G stands for genetic, and there are various genes that we'll go over, some of which later in the talk. And then it could be autoimmune, and there are two distinct types of autoimmune disorders that can cause chronic pancreatitis. One is type 1, and that is histologically known as LPSP, and then type 2, which is idiopathic duct-centric chronic pancreatitis. These are totally different diseases. And then recurrent acute pancreatitis can result in eventual development of chronic pancreatitis. So if someone had a severe attack of acute pancreatitis that resulted in necrosis, eventually this is going to repair in the form of chronic pancreatitis. And lastly, it could be an obstruction. Chronic obstruction of the pancreatic duct by means of a tumor, a benign stricture, or a stone can result in further damage to the upstream pancreas, which eventually would result in chronic scarring. This is a cross-sectional image of basically how calcific large duct chronic pancreatitis would look like. This particular view on the CT scan to the right, you see these wide dots across the pancreas parenchyma suggestive of calcification. So this is enough of evidence to support the entity of calcific large duct chronic pancreatitis. Folks with chronic pancreatitis could present with no symptoms, and that's primarily the most commonly, I would say, observed finding, through which patients are unlikely to have any form of symptoms that they would declare, and this is more of an incidental finding on cross-sectional imaging. However, if they are symptomatic, then they're likely to present to us in clinic or in the hospital with pain, and that's about 80 to 90% being abdominal pain, typically in the epigastric region, and again, radiates to the back. It could be constant or intermittent with flares. And also, patients can present to us not with pain, but rather with evidence of glandular insufficiency. So one example is if they have lost or they have decline in their exocrine function, then this could result in fat malabsorption. So patients in that case would present with steatorrhea or fatty stool, which is typically a greasy stool. They see oil droplets in the toilet bowl, and they could have with it a malabsorptive syndrome. So they could have fat soluble vitamins deficiencies along with weight loss. And this is a complication that patients are increased risk for as they age, and typically can be corrected by means of exogenous pancreatic enzymes replacement therapy. While on the other hand, they could lose or have decline in their endocrine function, by which they would lose their islet cells, through which they could have a high risk of diabetes. And in this case, typically, it tends to happen later in the disease course, and that is seen in about 40% of patients. And almost always, this is going to be insulin requiring. And there is correlation between this problem as well as age, and in Black patients as well as those with obesity. Other complications that patients could be at risk for when they are dealing with chronic pancreatitis could include basically obstruction to neighboring organs. So they can have, from the scarring, bile duct obstruction, obstruction of the small bowel neighboring the pancreatic head, as in the duodenum. They could have leakage from the pancreas, and that could result in pancreatic ascites or pleural effusion. With chronic inflammation, there are risk of having splenic vein thrombosis, or I would say vascular thrombosis neighboring the pancreas that could result in also formation of pseudoaneurysm within these blood vessels. And lastly, patients with chronic pancreatitis are at a slightly higher risk of developing pancreatic cancer in the future. Additionally, this disease entity also is correlated with bone health. So osteopenia and osteoporosis can be seen north to 50% of patients with chronic pancreatitis, and that's typically more common in individuals who are older, smokers, and alcoholics. So in this case, we would need a baseline DEXA scan to identify the disease state or the complication and treat it adequately at the right time. Now, these diseases, as in acute as well as recurrent as well as chronic pancreatitis, over the past 2 decades, we have found from numerous studies that they are linked. They represent a disease continuum. Here's a meta-analysis that was published in Gastro back in 2015, looked at over 8,000 patients and pointed out that basically that one episode of acute pancreatitis can eventually progress to recurrent as well as to chronic. So the prevalence of recurrent acute pancreatitis from one single episode can be seen in about 21% of the time. And also there is a tendency to move from one episode of acute pancreatitis all the way to chronic pancreatitis by about 7% to be precise. And this is more common in those who have had their disease caused by toxins or essentially a toxin mediated pathway, so the smokers or the alcoholics. Recurrent acute pancreatitis per se, even in the idiopathic state, can transition to chronic pancreatitis in about 36% of the time. So one third of patients could transition from recurrent acute, even if it's idiopathic, all the way into chronic pancreatitis. So therefore, we understand that this disease is not as in acute as well as recurrent acute pancreatitis is still as morbid as chronic pancreatitis because there is a likelihood of that transition to happen in certain cases. And here's a study that actually looked at that in terms of understanding mental health impairment, physical health impairment from simple recurrent acute pancreatitis against chronic pancreatitis. So they've collected data from patients who have had recurrent acute pancreatitis and those who have had chronic pancreatitis against non-disease controls. And this is a sizable cohort. And you would see, based on physical component summary score as well as the mental component summary score, in this particular table, that the drop or decline in physical basically score is significant compared to non-disease controls. It's less compared to chronic pancreatitis, but still evident. And that's again repeated when it comes to mental health score assessment with recurrent acute pancreatitis cases against controls, which is actually close to chronic pancreatitis in that case. We know for a fact that chronic pancreatitis is a problem because if they present with pain, if patients with chronic pancreatitis come to us with pain, we know this is not an easy symptom to manage. And also with it, there is the disability, there is potential narcotic addiction, and also it also would cost the healthcare system quite a bit of money. And therefore, my goal as a treating gastroenterologist and a pancreatologist is to treat early, to find the cause. I try my best to reverse that cause, educate patients, and engage other specialists around me to help that patient feeling better and then hopefully preventing downstream complications. So the best holistic approach to chronic pancreatitis or acute pancreatitis is understand that there are certain prevention steps that we should go for in order to prevent disease recurrence and downstream complications. So if you look at primary prevention, this speaks about general population education. So this starts at the community medicine level at primary care physician offices, where we're talking about encouraging patients to cut back on smoking, alcohol, improve their basically physical health so there is less obesity. As we know, these are factors that could eventually result in disease. But unfortunately, most of the time, as gastroenterologists or even hospitalists, we're dealing with the second basically bucket, where patients are presenting to us with acute pancreatitis and they've already been exposed to these risk factors prior. In that case, we would still want to re-emphasize on controlling risk factors, but also this is when we want to extensively look for the cause, because if we're able to find it and then not to say cure it, but reverse it, then probably we are likely to prevent one, recurrent acute pancreatitis, two, evolution into chronic, and lastly, complications, which is basically what we want to prevent in the tertiary bucket or in the third bucket. And in that case, if we are dealing with an individual who is known to have chronic pancreatitis, but yet without gland dysfunction, then we have to know who is at high risk for that. And again, educate about the risk factors, screen for those basically complications soon enough by checking A1C levels, fat soluble vitamins, get a DEXA scan. So therefore, we're able to be ahead of the game and correct those problems from happening in the future. That's the ideal approach when we're dealing with any case of acute pancreatitis or even chronic pancreatitis. So my goal as a treating pancreatologist is basically understand which patient is likely to progress from acute to chronic, understand who is at high risk for future pancreatic cancer among that cohort, and do my best to provide early interventions to prevent this sort of progression of disease, even if it's surgery. And lastly, which is, I would say, it should go all the way to the top, is trying to basically narrow down my testing to order what would be relevant to and then prevent unnecessary testing. With that being said, moving to the topic of interest, and that's genetic induced disease. There are many pathological pathways of how pancreatitis can be induced by a genetic background or a genetic mutation. And this actually dates back to the 50s. So the first described potential genetic induced pancreatic injury was back in the 50s by Dr. Comfort here at the at Mayo Clinic Rochester. At the time, they could not actually identify an actual mutation. But later in the 90s, when Dr. Whitcomb from University of Pittsburgh narrowed this down to PRSS1. So PRSS1 as a cause for what we call as hereditary pancreatitis was discovered in the 90s. And as you see further down, further downstream, there were more genes that were developed, or not to say developed, discovered that were found to be linked to pancreatic injury. So CSR, loss of function, was in 2003. You have CAL in 2006 with loss of function variants, PNLIP in 2015, and the list goes on. But when I clinically think of a genetic induced problem, then I have to look into what pathway this genetic mutation is affecting, at what pathway this genetic mutation is affecting the pancreas, and therefore able to maybe narrow my genetic testing and at the same time understand how would that sort of affect the patient in terms of symptoms and also the morphological appearance of their pancreas on imaging. So there are three pathways that we think through, one of which is a trypsin-dependent pathway, and a second is a misfolding, and this is all at a microcellular level. And the third is a ductal pathway. And you see these genes are responsible for these abnormalities. So if I want to dive a little bit into a cellular level when it comes to trypsin, so what trypsin is in need for is basically to help it with digestion. And that is typically activated by intracellular calcium, let's say within the acinar cells. There are certain genes that would promote calcium release, and there are other genes that would basically downgrade or kind of lower calcium, intercellular calcium release, and therefore that would help with trypsin degradation. So if you take an example of PRSS1, PRSS1 is a gain of function type of a gene. So mutation in this would result in much more trypsin production than what we need, and therefore it would result in overwhelming the system and autodigestion of the gland. While if you take CSR or CTRC, these are genes, if mutated, that would result in failure to degrade trypsin. So there's not much more stagnation of trypsin within the gland, for which you would end up with autodigestion. If I take it further into basically how the other ones would affect the pancreas and causing pancreatitis, take an example TRPV6 or CFTR. These are not going to affect the trypsin production, but what they do is they would stagnate flow within the ducts, and that's what I mean by a ductal pathway. So now there is more trypsin sort of sitting in traffic within the pancreatic duct, which would result in basically viscous fluid, and there is more activation of those trypsin molecules, and there is more intercellular calcium, which eventually would result in autodigestion and eventual pancreatitis. So, one way or the other, these genes could have a different morphological, if they are mutated, morphological appearance of the pancreas, and therefore, in certain age groups, I'm able to tell maybe at one level what gene is likely going to be affected or mutated. And this is basically what this would look like at a macro level. So typically the pancreas is stimulated, and that would release pancreas enzymes, including trypsin. Trypsinogen will be activated in the duodenum, and here we go with basically the function. But if you have an acinar cell error, then you're likely going to result in premature trypsinogen activation, and that could be related to a calcium regulation problem, which are the basically causes that I went over earlier. But here is another cause, which is CSR mutation that's known to affect calcium regulation. It could be a trypsin-related problem within the acinar cells, and these are the other genes: PRSS1, CTRC, SPINK1, or if someone has severe kidney failure resulting in acidosis, that could also result in trypsin premature activation. It could be a ductal problem. So again, a secretion issue, CFTR mutation, TRPV6, Claudin2, all of those would result in stagnation of flow and again, premature activation of trypsin. Similarly to what we see in any case of duct obstruction by means of a gallstone, by means of pancreatic duct stone, an obstructing tumor of the pancreas, this would have pretty much a similar look to it on imaging, and therefore we can predict what disease state are we dealing with and caused by which mutation. There are some unclassified, basically, genetic mutations, and they're the ones at the bottom. We know they can cause misfolding of protein, but yet we're unable to put them basically within actual mechanistic scheme of how they end up causing pancreatitis acute or chronic, such as CL or CPA1 or PNL-IP. And eventually, this is the clinical syndrome that we will be getting, which is pancreatitis. Now, speaking a little bit about hereditary pancreatitis, before I get to it, I have to start by saying pancreatitis is a complex genetic disease. I don't believe it's one cause. It's likely going to be a combination of things. Ideally, this inflammatory condition would result in someone who's susceptible to injury, someone who might have an underlying genetic risk factor, and then you add to it an environmental factor such as drinking, heavy drinking, or smoking that could accelerate this disease and make it more apparent. So you have more of a disease modifier, and then you add to it this insult, and by means of a toxin, and therefore they are to develop early onset disease. Hereditary pancreatitis, in particular, as I said, it is the first mutation that was discovered and known to cause genetic induced disease. And the name hereditary pancreatitis is almost specific only to PRSS1 induced disease. Penetrance in terms of PRSS1 causing pancreatitis has been seen in 80% of folks with PRSS1 mutations. However, I believe this is overstated because this is older data, and primarily we were testing patients who were known to have PRSS1 mutation, and we're not basically testing the mass public. So I believe that number is less, but yet it does have high penetrance. Of all comers with pancreatitis, genetic induced disease can be seen in 1% of all pancreatitis cases. The prevalence is less than 1 per 100,000, whether it's in Europe, here in the US, or in Asia. And this is a table coming from an Australian study that basically highlights disease incidence over a good over 20 years of data, worth of data in each of these continents. So if you take an example, Europe, over 400 patients who have had genetic induced disease, majority of which were PRSS1, but you get to see less of SPINK, less of CFTR, and this is likely because of lack of testing, not necessarily because this mutation has not been discovered. The other genes they would have, and one thing I should mention about PRSS1 from the prior slide that this is an autosomal dominant disease. So you are likely going to see disease in basically that family by means of about 50%. But when it comes to the other genetic mutations that can cause pancreatitis, across the board, they're almost all autosomal recessive, and therefore they are heterozygous, and you might not see high penetrance, and therefore, most of the time, these are disease modifiers as opposed to causing disease by themselves. So typically, you would see it along with another risk factor. So if you take CFTR as an example, this is not a homozygote, basically genetic mutation, which is what we see in a full-blown cystic fibrosis. This is a condition that will happen in the absence of cystic fibrosis, and we know that we have at least 9 mutations that has been identified and recognized in causing idiopathic chronic pancreatitis, and the list keeps increasing year to year. And luckily, we have some therapies that could be offered to modulate those genes and hopefully reduce the risk of recurrent acute pancreatitis in the future, as well as chronic pancreatitis. SPINK1 is an autosomal recessive disease. This is the first line of defense in terms of flushing out trypsin from excess trypsin from the pancreas. So if it's defective, then you would have trypsin stagnation and disease eventually. Interestingly enough, there was an entity of chronic pancreatitis known in Southeast India called tropical pancreatitis, which initially thought to be dietary related, but later on it was found that this is actually linked to SPINK1 gene mutation. Both CTRC and CSR, they are, if mutated, they would result in failure to degrade trypsin, and that eventually would result in autodigestion of the gland. Interestingly enough, CSR tends to be more common in alcohol-related disease. So again, a disease modifier. CPA1 could result in early onset gland dysfunction. So those patients are typically asymptomatic, but whenever they reach their 40s or 50s years of age, they tend to present with exocrine dysfunction or diabetes. The risk of cancer has been debated, but it could be elevated in that particular cohort based off small studies, but this would require further analysis. This is again just to summarize what I went over. The one thing that I want to bring to your attention, if you look at the very bottom when it comes to CFTR, the common mutation that we see is a delta F508. This is highly pathogenic, and if seen, then this is likely going to cause disease, whether it's acute pancreatitis or eventual chronic pancreatitis. And as I said, luckily we have gene modulator therapy that would help in improving the function or augmenting the function of that gene. And it has been studied that it does reduce the morbidity of pancreatitis downstream. Now, also we know for a fact that those individuals with an underlying genetic cause, they are at higher risk of having acute pancreatitis into recurrent, into chronic pancreatitis compared to those with a without an underlying genetic etiology. So here's a study from Cincinnati children by Maisam Abu Haija, published in 2019, that basically evaluated patients with genetic induced disease versus those who are not, and looked at the risk of recurrent as well as chronic pancreatitis. So to the left, you see here that those with, let's say, SPINK1 or PRSS1, they've had much more recurrence of pancreatitis sooner compared to those who did not have an underlying genetic etiology. Nonetheless, it took less time for them to progress to chronic pancreatitis, especially if they've had multiple genes affected compared to one gene, or basically those without an underlying genetic disease. So we know for a fact that those individuals are likely to progress much sooner, and they would have, I would say, higher disease-related morbidity earlier in their life. Now, who should we test? This is the list that I go by. The ones that I would want to consider for genetic testing are the ones with early onset acute pancreatitis. You have a child who comes in with acute pancreatitis, I would certainly consider genetic testing. Likelihood of landing a positive result is going to be high. Additionally, an individual who comes in with recurrent idiopathic acute pancreatitis, uh, less than the age of 35, typically a younger population. And again, when I say idiopathic, that means those who do not have a clear cause, like no history of heavy alcohol use, no history of smoking, no biliary etiology. We've done our due diligence and looking through the whole list. That is a bucket or a chunk of patients that I would want to consider for genetic testing. Also, those who comes with they would present with early onset chronic pancreatitis. All of a sudden, we see on a scan calcifications. Patient never had any pancreas insult before that he or she knows about, and they're younger younger as far as their age. This is when I'm thinking also probably there is an underlying genetic etiology. Relatives to individuals basically with known mutations, primarily PRSS1, can be tested. Additionally, if I know that there's an underlying CFTR associated disorder, so there is male infertility or pancreatitis, so not full-blown cystic fibrosis, and I'm thinking, well, on the scan, the pancreas looks a little abnormal, then we might consider basically genetic testing to tease out if they have an underlying CFTR mutation causing basically that pancreatic morphological abnormalities. Family history for chronic acute pancreatitis or idiopathic chronic pancreatitis can be considered, but I would typically consider that if I have a patient who presents to me with pancreatitis themselves, not everyone. What we don't do is basically assessing pancreatitis above the age of 35 by means of genetic testing. That has not been agreed upon, I'll say, yet it does have value in certain cohorts. We don't typically consider pancreatitis, the genetic panel for pancreatitis in an individual with family history of pancreatic cancer outside of PRSS1. And lastly, we don't often look into that sort of risk modifying sort of type of analysis in an individual with a known cause. An example, someone who has background history of smoking or alcohol use typically would label those causes as the one driver for their pancreatitis, but I often look into the time of exposure. So if a patient exposure to smoking has been limited only to 2 to 3 years, and now they're developing acute pancreatitis or recurrent acute pancreatitis, then I would want to think that maybe they are susceptible because they have an underlying genetic mutation. These are discussions that I have with patients, and these are discussions that I would have also with trainees by telling them, again, this is a complex disease and it's unlikely to be one reason only. And lastly, a condition called pancreas divisum has been linked to chronic pancreatitis as well as recurrent acute pancreatitis, and that's a congenital abnormality or anomaly within the pancreatic duct if linked with an underlying genetic mutation. So if I have someone who presents to me with recurrent acute pancreatitis, or all of a sudden they have this chronic pancreatitis, and I see this morphology or anomaly on their pancreatic duct on a scan, I wouldn't call this obstruction by this anomaly, but rather I think there's an underlying cause, and often this is going to be a genetic induced disease, and primarily in that group it would be CFTR or SPINK1. Now, a question that come in clinic quite a bit: if a patient has underlying genetic or hereditary induced pancreatitis, then are they a high risk for future pancreatic cancer? The answer is that this has been looked at across many studies, and every single one of those gene mutation might have a very different outcome downstream. But uh, the idea is not necessarily that the gene mutation in and of itself is a carcinogenic, but rather the fact that these individuals or these patients could have developed chronic pancreatitis much earlier in their lifespan, and therefore they are living in this chronic inflammatory state longer. So if a patient develops chronic pancreatitis at the age of 20, as an example, because of an underlying PRSS1 mutation, and their expected lifespan is to the age of 80 or 85, that means a little over 60 years of chronic pancreatitis versus someone who develops chronic pancreatitis when they are 50 years of age and they have only 30 years, let's say, of life expectancy. That is potentially the reason why these folks are high risk for future pancreatic cancer. However, when it comes to PRSS1, historically speaking, the risk of cancer has been reported in various studies. So in the 90s, it was thought that this was up to the 40% range, which was quite high. And then later on, we found that this is actually biased or confounded by smoking. So in early 2000, the range actually changed quite a bit, between 7 to 18%. The most recent study is actually it's over 15 years old now, and it did highlight that it is about 70%. And that number increases with age. So the risk of pancreatic cancer in, let's say, a PRSS1 induced chronic pancreatitis at the age of 50 is actually less than 1% compared to someone who is at the age of 70, which tells us there's another factor. Maybe, again, living through the disease state longer is likely why they ended up with pancreatic cancer downstream. So we can say that maybe they're a higher risk for pancreatic cancer, but this accounts for a very small number of all comers with pancreatic cancer. What are the recommendations when it comes to a known hereditary pancreatitis case or those with an underlying genetic mutation causing pancreatitis? If we take CAPS, which is a consortium effort that looks into screening for pancreatic cancer, they actually recommend screening in those with PRSS1 mutation, CPA1, and CTRC mutation, knowing that this is potentially a higher risk, for which they'll recommend getting an MRI or getting an endoscopic ultrasound at particular age groups and going forward. However, a much more robust sort of group of pancreatologists looked into this, and they came up with a very different recommendation. So when it comes to PDAC risk or pancreatic cancer risk, in the ones who are uh, having underlying hereditary pancreatitis related to PRSS1 mutation, there is decent level of agreement that the evidence is high enough to justify surveillance in that particular population, but not with the others. And that's something that is, again, worth a discussion in clinic, because we need obviously more data to understand the longitudinal risk for cancer. So as it stands, in my practice as an example, the one case where I would want to truly screen for pancreatic cancer is the case that has known PRSS1 mutation that's pathogenic causing pancreatic disease. But all the others, it's a discussion that I have with patients, but I always keep an eye on them. So not necessarily I would want to enroll them in a form of screening protocol. What do we do if we have someone with basically genetic induced disease that's highly morbid? Pancreatic surgery is an option if there's no drug therapy for it, and it could include removal of the pancreas, but also in certain cases, if the pancreas islet cells are reserved or preserved, I'm sorry, and this is an early onset disease, then removal of the pancreas and isolating the islet cells, injecting them back into the liver, is a procedure that we call TPIT, and that would allow for removal of the affected gland, but at the same time, it would preserve or lower the risk of future diabetes to some degree in that particular patient group. Um, I'm going to wrap up with a real case that I had met a while back. This is an individual that I treated for recurrent acute pancreatitis who have had multiple tests to identify the cause. He had a pancreatic cyst, and the cyst was thought to be the cause of his acute pancreatitis, and he was offered surgery. So initially he had a genetic panel that was negative, but later on we got another genetic panel that was expanded. So it came back with a mutation. This mutation is of uncertain significance, but in a case of such, we at least are trying to tell the patient that maybe in the future this mutation could materialize into being known as a pathogenic. So he's involved in a research study, and at the same time, we clearly stated that the cause of his pancreatitis is not due to the cyst. So we avoided a morbid surgery that's unnecessary. So that's the idea behind analyzing cases when they come to us with acute pancreatitis, and we're thinking of a genetic potential or a genetic background. Lastly, there are a few things that has to be considered whenever we're ordering genetic testing. First, we need to get the consent from the patient. Any patient who is getting genetic testing has to be counseled, whether it's by us in the clinic or through a genetic counselor. But they need to be talked about in terms of what this would entail. How is the testing going to help them? They would go through their family tree and understand their history as well. Also, another factor that has to come in play is understanding the cost. How much is this going to cost them? Uh, Additionally, in certain cases, not in all countries, insurances can be affected by the results of these genetic tests. So we have to make sure that they are comfortable with that. So you don't want to go ahead and order a genetic panel and there's a result that's positive and this is going to affect their life insurance plan. So these are points of discussions that should take place before we go ahead and order the test, even if a patient is eligible to be tested for. So with that, I will hand it back to Dr. Hasadri, and I know she has additional points to highlight here before we wrap up.
Dr. Ashkar, go ahead and share my screen. Okay, perfect. Well, in the same vein as what Dr. Ashkar had just discussed, as he ended with a really meaningful clinical case, I also want to start off with a patient impact story that I think really highlights the need for greater awareness of hereditary pancreatitis in particular. That hereditary pancreatitis, or HP for short, actually is a thing. And that genetic testing for this disorder is not an endpoint actually for our patients, right? It is the start of a new journey for them. And so I'm going to share the story of Christine, who this is actually publicly viewable on the web now. She shared this with multiple patient advocacy organizations. So I'm not presenting anything confidential here. But let's start off with a quote from her. So she mentioned that I was in the hospital for about 4 days, and they ran a genetic panel that included cystic fibrosis and other known mutations. As I was checking out of the hospital, they informed me that the test results showed that I have hereditary pancreatitis, PRSS1 gene mutation. They didn't explain to me that recurrent acute pancreatitis can easily turn into chronic pancreatitis. They didn't explain to me that pancreatitis leads to a higher risk for pancreatic cancer. In hindsight, it seems that they were more interested in determining why a young person had pancreatitis instead of explaining what that meant for me and my life. To me, it wasn't groundbreaking news that it was hereditary. I already knew because my cousins had it. I didn't know hereditary pancreatitis was rare, untreatable, or that it could be so incredibly life-changing. I thought I would have to manage my lifestyle to avoid getting acute pancreatitis. I just didn't know. So again, there's the testing itself, which I'm going to go over a bit about how it's done. But then there's how do we get those results? And then more importantly, what do we do with those results? Because again, for those patients, what they need to be counseled on, how they're managed, what they need to be prepared for, all of that changes, right, when that result comes in. So how do we actually get that result then? So in terms of molecular genetic testing, there are a few approaches you can take when it comes to either ruling in or ruling out. Because again, in the context of a genetic disease, remember that a negative result can be just as powerful and meaningful for a patient, right, as a positive one. And so when it comes to ruling in or ruling out a diagnosis of hereditary pancreatitis, one could start with, for instance, single gene testing and take a tiered approach. You could do serial gene testing, starting with, say, PRSS1. If this is the approach that is taken, it is often done with a technique such as Sanger sequencing, which may or may not be supplemented with another technique to look for different types of variants, or it can be done with next generation sequencing instead, which is what most labs have adopted nowadays. You could also do a multi-gene panel. That's always going to be, or almost always going to be done by next generation sequencing or NGS. And then there is, of course, the everything, including the kitchen sink approach, which is whole exome or whole genome sequencing, which is also done by NGS. So let's talk a bit about the pros and cons then of each of these different testing approaches. When it comes to serial single gene testing, say starting with PRSS1, the beauty of Sanger sequencing is that it is a really fast and cheap technique. However, it does not detect copy number variants. So if you have a large deletion or large duplication in your gene, it is not going to be picked up by this technique alone. We do know from experience, though, that single gene testing is often well reimbursed by insurance. Even if you take a tiered approach, sometimes insurance requires you to take a tiered approach before they cover any other genes. They want you to start with PRSS1 if that's negative or equivocal, then they'll cover the rest of the genes that you're interested in. However, if we take a tiered approach, of course, that can slow down the time or delay the time to diagnosis, if you will. And it can actually end up being more costly, right, with the more genes that you have to test in succession of one another. So one could then consider a multi-gene panel approach instead, where you could actually interrogate hundreds of genes simultaneously with one technique, and that would be NGS or next generation sequencing. the beauty of MGS is not just the ability to more comprehensively test more targets, but you can also detect copy number variants, which, remember, again, with single gene testing by Sanger sequencing, you're going to miss those. The problem is the more genes you have, the more potential you have for finding variants, and even having genes of uncertain significance be part of that panel and part of the result. And so those can be a very slippery slope for both providers, such as Dr. Ashkar, as well as his patients, right? Because that there is a lot of nuance, again, into counseling those patients as well as managing those patients, and still plenty of unknowns in that space. And when it comes to multi-gene panels, not all genes that are associated with hereditary pancreatitis may be included on that. And the sensitivity for each gene you have on there is definitely going to vary between labs. And that can change for sure over time. When it comes to comprehensive testing, however, so we're thinking, again, whole exome or whole genome testing. So again, this is the leave no stone unturned approach. These are more exploratory in nature, at least from the perspective of insurance payers. And so even though this test is very comprehensive, I mean, this is the most from a molecular technology standpoint that we can offer patients at this time. I mean, we're looking at, 20,000 genes simultaneously with these technologies. Because of that, you have the greatest potential for new discoveries. So patients who are negative by a multi-gene panel, for instance, this might be their next stop because they could have something new and undiscovered going on that's only going to be picked up by a technique like this. But because it's more exploratory in nature, it's not well reimbursed for in the context of hereditary pancreatitis by insurance at this time. Because it's so large and comprehensive, it's going to be the most expensive test, and it's going to have the longest turnaround time in most cases. And then you take the issue of having variants as well as genes of uncertain significance to an exponential level almost when it comes to something like whole genome sequencing, unfortunately. Yet also fortunately, because again, there is the potential for newly discovered gene disease associations to be made with this. Then there is the issue, actually, it could be a benefit, but it could also be a problem of secondary findings. Not all patients necessarily want to know, for instance, that they actually have a hereditary cardiac arrhythmia, for instance, that was uncovered by whole genome. And then that necessitates Dr. Ashkar, for instance, in having to refer that individual to a cardiologist and other specialists and a whole other cascade of testing and workup that has to take place that the patient may not have been prepared for at that moment. And the thing about whole genome as well as whole exome sequencing is that they're often most powerful when they can be performed on trios of individuals or more. So not just the individual who you suspect of having that genetic diagnosis, but their parents, for instance, or other first-degree relatives. When you can test all of those individuals at once, that really does improve the sensitivity and specificity of your analysis. But again, that can add to cost, that can add to turnaround time, and you won't always have those family members available for testing. There are limitations, of course, to NGS itself, which is what we're using for those multi-gene panels, as well as whole exome or whole genome. There are certain variants, for instance, that can be very tricky to detect as well as characterize. So things that are deletions or insertions of larger than 40 base pairs, variants that are in regions of the genome that aren't typically interrogated by a multi-gene panel. So introns, the promoter regions of genes, those often are not covered. If we do detect a large deletion or duplication, we can't always accurately resolve the breakpoints of that with a multi-gene panel. Certain large structural rearrangements are not going to be amenable to this technology as well. Mosaicism, so if a patient has a variant that is present at a very low allele frequency, so not 50% or 100% of their DNA has that mutation present, if it's only present in, say, 10% of their DNA, we may not be able to pick it up by NGS. And then there is the beware of false positives that Dr. Ashkar mentioned earlier. So there are certain regions of the genome that are high complexity or low complexity that can make testing really tricky. And PRSS1 is actually a really classic example of this. So PRSS1 is a gene that has really high homology, over 90% identical in DNA-based sequence to another, we call it pseudogene known as PRSS2. And so if you're doing next generation sequencing without something beforehand that can enrich for PRSS1 as opposed to PRSS2, you can actually pick up variants in the other gene, and your bioinformatics pipeline that you're using to analyze your data can actually map that variant or tell you that it's in the wrong gene. And so you could be actually seeing a variant that's in PRSS2, which could be of no clinical consequence to your patient. But based on your pipeline or your technology, it could be called as being it's in PRSS1 when in fact it's not. And so with this, false positives as well as false negatives, in particular for PRSS1, are very much a possibility. And even here in the lab at Mayo, we've actually had 3 cases and counting where individuals were found to be previously found to be positive for what were called pathogenic variants in PRSS1 that were sent to us for confirmatory testing, and we found that they were actually in fact negative for those variants. And again, that's going to be life-changing as well. And so there are additional challenges as well to the genetic testing. I have the privilege of working with 4 just phenomenal, dare I say, best in the world genetic counselors that really have subject matter expertise in the genetics of pancreatitis. So that would be, in particular, Juan Cabral, but also Melanie Meyer, Erica Stelmach, and Madeline Lepore. They really are masters at this art, interpreting variants in genes for a common but complex, highly complex, and often multifactorial disorder like pancreatitis. Like I said, it's just, there is an art to it, and who is looking at that data and analyzing it definitely makes a difference. And you do see very highly variable laboratory experience and expertise with these genes and variants across the world. There's also, to additionally complicate things, a new risk allele classification system that professional societies are now recommending we adopt for these genes. So this can be incredibly confusing for providers and patients. I mean, for instance, if you saw a report that said pathogenic variant, that's probably going to land differently for you than if that report says, say, established risk allele, right? Or if something says a variant of uncertain significance, i.e., we don't even know whether it causes disease or not, versus a variant of very clinical consequence. So we know it can cause disease. We just know that what symptoms of that disease can vary from individual to individual. Again, those classifications matter, and how they land with your patients as well as with providers definitely matters as well. Again, there's the clinical utility of certain genes. So it is really difficult to prove causal relationships between this type of phenotype, something as complex again as pancreatitis, and a particular gene. And so there's a lot of conflicting evidence out there in the literature for these gene disease associations. And so what genes even are included on a multi-gene panel can vary greatly between labs. And again, the clinical utility of those genes is going to very much vary as well. And because of that, again, ordering providers may have various or differing comfort levels, if you will, when it comes to ordering the testing, as well as what to do with those results. And of course, patient access to genetic specialists, such as genetic counselors, or again, specialists such as Dr. Ashkar, may be limited. And so that's something we have to consider as well. So despite all these challenges, though, there is, of course, I want to circle back to the patient impact, much like Dr. Ashkar did earlier, and speak to, again, the clinical utility of genetic testing, why it matters, why it can have such a profound impact on our patients. And so this was the case we actually saw in the laboratory. So again, I want to give a shout out to Han Cabral for her work on this case. And this is actually her slide that I'm showing you today. This was a 3-year-old girl who had acute pancreatitis, her first episode actually of acute pancreatitis at the age of 2. So just as a toddler, she already had pancreatitis, followed by another episode within months of that. At the time she was diagnosed, no surprise there, with recurrent acute pancreatitis. And her family history was actually quite remarkable. It was remarkable that her mom also had a history of pancreatitis, with her first episode being at the age of 12 years. And so an NGS-based multi-gene panel was ordered, very appropriately so in this case, and we found a PRSS1 duplication. So this is extra copies of a portion of the PRSS1 gene. This is a type of mutation, again, that we would not have been able to pick up by Sanger sequencing, yet here we are seeing it beautifully by NGS. And duplications in this gene are actually incredibly rare. And because of that, they are very tricky to classify. One would default in a genetics lab to perhaps a variant of uncertain significance in this case, because they are so rare and we don't quite know what extra material, and again, depending on the breakpoints of that duplication, what impact that could have on gene function. But in this case, we had actually previously seen in our own lab 2 other patients with this type of duplication. There was another pediatric case, in fact, who was 3 years old, coincidentally, that had this duplication, and then an unrelated adult patient who was 45 years old at the time of presentation who had the same alteration. So because of this testing, this patient's diagnosis is now different. They no longer have recurrent acute pancreatitis. It's no longer RIP, it's HP. They've got hereditary pancreatitis, completely different ballgame, right? And it's very evident from what I'm showing you here on the slide that hereditary pancreatitis can very much have incomplete penetrance, and it can have variable expressivity, just looking at, for instance, the age of onset in the patient's mom. So again, I think this really underscores that. And so I want to circle back then one final time to, again, patient impact, clinical utility, and then close with some words of wisdom from our friend and fearless advocate, Christine, again. So the last thing I will say is if you have been diagnosed with recurrent acute pancreatitis, have pancreatitis at a young age, or have been diagnosed with chronic pancreatitis, fight, fight, fight to be tested for the known genetic mutations. I would not assume that just because no one in your family has had symptoms that there's not a genetic link. First, my mother has no symptoms. Second, medical problems of your extended family may not be shared or known. And pancreatitis is a complex disease and presents very differently in each person, even for people with the exact same mutation. I would also say that the earlier that one knows of the identified mutation, the more active you can be to help fight for a cure while you are not battling a chronic disease. Any family with a genetic mutation will have to deal with this disease for every generation. With that, I'll hand it back to Dr. Ashkar.
Thank you for the opportunity, and I'll be more than happy to take questions, if any, before we wrap up.
As a patient-facing provider, how does having a positive result, so say a pathogenic variant or an established risk allele is found in your patient, how does that change the management, the surveillance of that patient for you?
Well, thank you for a great question. So this is a very common scenario. First of all, we're often dealing with this problem if we're suspecting it ahead of time. So I always prime patients of that possibility. Means if I have someone who's younger and I test for an underlying potential genetic mutation, then I'm thinking about it, then I will let them know ahead of time that this is very likely to be the case. And then we would lay out the longitudinal expectation in terms of disease-related morbidities. For instance, most of patients with SPINK1, they're very likely to have early onset gland dysfunction, for which I will tell them there is a decent chance at one point that you will be placed on pancreas enzymes. There is a decent chance that you might end up with diabetes. We don't know about your main risk for future pancreatic cancer as much as, let's say, PRSS1. So that's in and of itself good news, but still we would want to keep an eye on things. And then also discuss with them expectations as far as that this is going to be also a changing field. So maybe in the future we would consider pancreatic cancer screening in that cohort, and therefore they're ready to hear about it. The most important thing that I always press patients on is avoiding anything that would basically make the pancreas a little further angry. So those are the folks that I would absolutely would want to counsel them about heavy smoking, heavy drinking. That would be the case with certain mutations, but those with early onset acute pancreatitis, and I'm highly expecting PRSS1, then I have to speak with them about disease-related morbidity, but I also have to speak with them about expectations within their disease course as they live longer. With this particular condition, patients are likely to have multiple episodes of, I would say, acute pancreatitis attacks almost back to back in their early life. But once they hit their 20s or so, they're likely to have less acute pancreatitis at the expense of developing chronic pancreatitis that often might be asymptomatic. And therefore, I'm sort of setting the stage for this sort of future expectations, but also talking about risk factors modifications, because the risk for cancer in that particular population would be a little bit amplified compared to the other mutations. So the mutation in of itself we'll have a very different discussion that I will have with folks and expectations. But I'm also open to discussing the ones with variants of unknown significance, because I would tell them we don't know today if it's causing your disease, but keep an eye because that could change in the future. So therefore, these discussions might come back again in the future. So it's a pretty dynamic discussion, I must say, when I have it with these folks.
Thanks so much, Dr. Ashkar. Well, seeing no additional questions, I just want to take a moment to thank everybody for participating in today's Present Approaches to Testing webinar on genetic testing for pancreatitis. If you do have a question that wasn't addressed today during our session, or if you have additional questions that you think of, please include them in the evaluation. Again, you can reference the link in the chat to access that evaluation now if you'd like. Laboratory credit is extended for this program, and so upon finalizing your evaluation, you'll have the option to claim and print your certificate.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.